much. Thanks to the cancer support community for having me here to give this talk, and hopefully it's useful to everyone. So I'm going to be talking today about gynecologic cancers. Get over to the screen. We're going to be covering cervical cancer, uterine or endometrial cancer, vulvar cancer, ovarian, and vaginal. And for each of these, we'll be going over some of the relevant anatomy, the incidence, risk factors, screening and prevention if that is an option for that particular cancer, and we'll touch on treatment. So the first one that we're going to cover is cervical cancer. And this is a diagram of the female anatomy. The cervix is down here. It's the beginning part of the uterus. In here we have the uterus itself and the endometrium, which is the inner lining, the tubes and ovaries. And most cervical cancers form on this outer portion here of the cervix, but some also form in the canal there. And cervical cancer is the third most common gynecologic cancer in the United States, but the fourth most common cancer overall for women worldwide. Here, as you can see, it doesn't make the top listing here in terms of new cases of cancer or deaths from cancer. But that's not necessarily the case worldwide. Tends to be in the lower resource countries. You can see over here in Africa, the incidence is much, much higher than it is for Europe or United States, Australia down here. And the reason for that is essentially Pap Smear screening. So here in the US, we have certainly a very good program of getting regular Pap smears for women. And the US Preventative Task Force currently recommends for women ages 21 to 65 to have a Pap smear every 3 years. That doesn't necessarily mean only seeing your gynecologist every 3 years. Often you'll see gynecologists for a yearly exam during those years, but the Pap smear itself only needs to be done every 3 years. And then if you're in the 30 to 65 age group, you can lengthen the interval between your Pap smears by having HPV testing at the same time. And so with that combination, you can potentially do it every 5 years. And the Pap smear basically involves, they put a speculum in, as I'm sure many have had, and basically use a little swab and a brush to get some cells from the outer part of the cervix here, and then the little brush goes into that canal to try and gain some cells from that inner area there as well. And then they look at those cells and see if they look abnormal. And with that, we're able to catch cervical cancers much earlier than they would otherwise be detected. And so when can Pap smears stop? So as you saw, that's up to age 65, and you can stop doing your Pap smears at age 65 if you've had at least 3 prior Pap smears, consecutive Pap smears that were negative, or at least 2 with the Pap smear and HPV that were negative in the past 10 years, with the most recent test in the previous 5 years. If you've had a hysterectomy and the cervix was removed, you can also stop screening as long as you don't have a history of a high-grade precancerous lesion or a history of cervical cancer. In those cases, screening needs to be continued for at least 20 years. And the main cause of cervical cancer is the HPV virus. So the human papillomavirus is a sexually transmitted infection that's quite prevalent. There's an estimated 74 million people in the US that have this infection, and 14 million new cases annually. Just having the infection doesn't necessarily mean that you will develop cancer. Not everyone that has it will, because most people will actually clear the infection at some point. But in some cases, it'll cause an abnormality in the cells that then causes the cancer to develop. There are more than 120 types of HPV virus, and most of them cause benign things like genital warts. The lower risk types, some of the more common ones are 6 and 11, tend to cause benign lesions, genital warts, or low-grade abnormalities. And they can also, up in the head and neck area, in the voice box, cause papillomas. And then the higher risk types include 16, 18, and there are others. And those are the ones that really cause more of the cancers and the high grade abnormalities in the cervix. And so it can cause quite a variety of cancer, not just cervical cancer, but also vulvar cancer, vaginal cancer, anal cancers, and penile cancers as well. And then outside of the pelvic area, also head and neck cancers, oropharyngeal cancers, so cancers of the tonsil or the back part of the tongue called the base of tongue, or the soft palate. All those structures are in the throat. And so it was first identified back in the 1960s that there was a relationship between sexual behaviors and cervical cancer, and ultimately cervical cancer cells were found to have this HPV DNA in the 1980s. And after that, a vaccine was developed, which first became available in June 2006. And basically, the HPV types of 16 and 18 account for approximately 70% of cervical cancers, but nearly all cervical cancers are caused by some form of HPV. And nowadays, since 2014, we've have a 9-valent vaccine available. So it covers all of these different types here. So it also includes the benign types, the 6 and 11, but 16 and 18 and other high risk types as well. So the recommendation in terms of vaccination is for children to get it at the age of 11 or 12, and that's been since 2006 for girls and 2011 for boys. And the idea with this is not necessarily that we want to vaccinate them so that they can become sexually active earlier, but really to catch children at an age before they've had any sexual contact, because as soon as you've already been exposed to the HPV virus, then that vaccine is not going to be as helpful. It can still cover types that maybe you haven't been exposed to, but most helpful if you really haven't been exposed to any of them. And so for patients that don't wind up getting it at 11 or 12, it is still recommended through age 26, excuse me. And it can even be considered for patients that are older, people 27 through 45, if they're interested in getting the vaccination, it's available. Although it may be a little bit less effective in this group because likely they've had sexual contact and may have been exposed to some of the types of the HPV virus. And along with that, so risk factors for cervical cancer are basically increased sexual contact. So multiple sexual partners, early age of sexual activity, high risk, having a high risk sexual partner or a history of sexually transmitted diseases, and as well as smoking, oral contraceptive use, low socioeconomic status, and actually non-white race as well. So there's a higher incidence of cervical cancer in non-Hispanic Black populations, Hispanic Latino populations, and Native American racial groups. And non-Hispanic Black women have the highest incidence of mortality from this cancer as well. Symptoms of cervical cancer, the most common would be bleeding, either having irregular bleeding between periods or heavy periods, or having vaginal bleeding after intercourse. As the cancer becomes larger and more advanced, there can also be other symptoms that might include strange vaginal discharges, pelvic pain, urinary symptoms if it's starting to affect the bladder, or blood in the stools. And in terms of treatment, so the cervical cancer treatments depend on how early you catch it. So if it's caught very early on, then these options up here are available. Cryotherapy, which just means like freezing a lesion off of the cervix, or laser ablation, so using a laser to eliminate it. loop excision or cold knife cone. Those are other ways that they can just focally remove part of the cervix that's involved. And then as it gets into later stages, then it's more extensive surgery or potentially chemotherapy and radiation. And so stage, because we were talking about these early stage versus later stage, what is that? Basically, stage is the extent that of a cancer in the body, and it's usually based on three things. So tumor size, or kind of where the tumor has grown into. That's the T part of it. It's called TNM. The N portion is nodes, so lymph nodes, and whether or not those are involved or which areas in some cancers. And then the M stands for metastasis. So that's if the cancer has spread somewhere else in the body, somewhere away from where it originally started. And so here, kind of see some examples of this. This is like that picture I showed initially, kind of a front view with the cervix down here at the bottom. And so this would be a healthy looking cervix if you were looking in with a speculum. It sort of looks like a little donut there. And then if you had an early stage cancer, it might be just some changes that you start to see right there around the opening, which is called the os. And then later stages, it's involving more of the cervix. And here in this stage, it's actually spreading outside of the cervix into the area next to the cervix, which is called the perimetrium. And there are more stages beyond that, but just because it kind of gives you an idea of smaller to, growing larger. And so we talked about here that part of the staging involves lymph nodes. So just what are lymph nodes? Basically, lymph is this fluid that's actually part of our blood. So in your blood vessels, you have red blood cells here, white blood cells, and platelets, and it's all in a fluid that basically gives that your blood, the fluid component, and allows it to circulate around. And part of that fluid leaves your blood vessels and goes out into the tissues as it gets further away from the heart to give nourishment to cells, so oxygen and food and things like that. And some of that fluid can go directly back into the blood vessels and then recirculate again. And some of it has to travel back through the lymphatic vessels. And so these lymphatic vessels are located all over different areas of the body, and they pass by these lymph nodes, which are just glands that have immune cells in them, white blood cells that are filtering that fluid and looking for bacteria, viruses, and just helping your body to fight infection, really, is what they're there for. And you have lymph nodes that are all over, in the neck, in the armpit area here, in this area, down in the groin, in the pelvis, which tend to be the ones that we consider for gynecologic cancers, although sometimes also the groin lymph nodes as well. And if you have a tumor in any part of the body and the cells become able to leave that tumor and travel somewhere else, then they can get taken up in these lymphatic channels, these lymphatic vessels, and then they get to the lymph node and they get stuck there, and they basically start to grow in that location and form another tumor. So when we're looking at staging a cancer and kind of seeing how advanced it is, the next place we're looking beyond where it started is those lymph nodes, and then also potentially looking further away at other organs and things like that. So going back here, so for the later stage cancers, if it's still a cervical cancer that's confined to the cervix and visible but relatively small, the surgery might include just taking out the cervix itself, but oftentimes if someone's going to surgery, it may be taking out the uterus and the cervix. And if it's a little bit larger, it's spreading, it's a larger tumor, or it's going beyond the cervix or into the lymph nodes, then if the person were to have surgery, generally radiation would be needed after that. And so oftentimes in those cases, sorry, I got motion detector lights in here, then instead of doing the surgery up front and the radiation plus or minus the chemotherapy, and giving someone the potential side effects of all of those treatments, a lot of times we'll just go straight to chemotherapy and radiation as the primary treatment. And as long as that cancer is still localized in the pelvis and not spread somewhere else in the body, then we're aiming for curative treatment with that. And so radiation is what I do at the City of Hope. And what that is basically x-rays is the most common form of radiation that we use. And most often those come from a machine. There are other sources of radiation, either neutrons or protons you might have heard about or seen advertisements for, especially for treatment of prostate cancer. Also carbon ions are used, although not so much in this country, but the most common one that we use is x-rays. And there's basically two forms of radiation. One is called external beam radiation. So in that case, you're lying on a treatment table and there's a machine that moves around you and delivers that treatment, or sometimes you go through a machine. And then the second type of radiation is called internal radiation or brachytherapy. And brachy means close. So in that case, we implant something into the body or put something into a cavity of the body to bring the radiation in that way. And it doesn't come from the outside in, it comes really from the inside. And we'll see a couple examples of that. But the radiation, the way that it works is that it enters and it excites electrons that basically are what really acts and does the work. But it affects the genetic material inside cells, the DNA. And so those electrons can either directly damage that DNA or they can create free radicals that then damage the DNA. And cancer cells just don't really have good mechanisms to repair this type of damage. So as they're trying to divide and grow, the damage ultimately kills them off. And normal cells can be affected by radiation because whenever we radiate an area, generally there are normal cells in that area as well. Actually, always there are some normal cells. And they can be affected. It can cause some inflammation for those cells, but normal cells have a lot of mechanisms for repairing this type of damage because we deal with it all the time. It can happen just spontaneously as your cells are dividing. It can also come from the sun, from chemicals in our environment, lots of different sources. So our bodies are very well attuned to being able to repair this damage. So generally, you'll get those inflammatory symptoms or side effects as you're going through radiation, and then your body will repair that and heal. But the cancer cells can't do that. So it kills them off over time, but it's not an instantaneous effect. We don't like give a treatment and then the cancer is gone the next day. Generally, it takes several days to weeks to start to see an effect on a tumor, and often it takes several months for us to see the maximal benefit of it. And this is an example of a radiation machine. Basically, someone would be lying on this treatment table here, and this big part behind just moves around and delivers the treatment. But it's all non-invasive. There's not any needles or cutting or anything. That just the X-rays just pass through. In this case, this would be for external beam radiation. And there are, other forms of that. But other types of machines, sometimes they look more like a CT scanner, like a tomotherapy unit, and there's various different brand names, but this is just one example of what's called a linear accelerator. And this actually produces x-rays from electricity. So there's not a radioactive source inside of this machine. It used to be back quite a while ago that the source in the machines would be cobalt, but not anymore really these days, except the Gamma Knife machine that does have a cobalt source. But most of them, the linear accelerator, is just producing it from electricity. And this is what an external beam radiation plan would look like. Nowadays, we tend to use IMRT or VMAT. So that's just a way of planning that basically means that the radiation's delivered as the machine rotates around, it's continuously giving radiation from many, many different angles. It doesn't just come from one direction. It used to be in previous times, probably back, IMRT started coming around in about the 90s. And so we used to do something like this, which is called 3D conformal radiation. And we still do treat certain areas with 3D conformal, but not so much in the pelvis as much these days, because as you can see here, this is, if the radiation was entering from like the front and the back and the sides, so just 4 directions, and it basically creates this box of radiation in the pelvis. And it's treating a very large area here, whoops, in trying to cover these outlined areas, which are basically the lymph node areas and the top of the vagina here. And so with that, you're treating a lot, and pretty much all of the bladder and bowel as well. And nowadays, we really have the technology to kind of shape the radiation field and carve it out from around. Here's the bladder here on this CT scan. These are hip bones on the side here. This is the rectum back here. And this is our target here in the middle. This is basically the part of the vagina there. So that's what we tend to do nowadays for treatment planning, and trying to spare, the side effects from treatment in the short term and also in the long term. And then with cervical cancer, so it would involve, if we were treating it curatively, not after surgery. If it was after surgery, a lot of times it would just be this external beam. But if we're treating it with just radiation and chemotherapy alone, then we do this part first, treating lymph nodes and the cervix and uterus and all those areas. And then in the second part of treatment, we do the brachytherapy. And this is a device called a tandem and ovoid. And it's basically inserted through the vagina this is a side view here. So this is the uterus, your bladder is in front of it there. This is the vagina. This is the rectum behind here. And this is the front view that we saw earlier with the uterus up here, the cervix here, and the vagina down here. And so there's what we call a tandem. That's basically a rod that goes into the uterus to give dose in there. And then these 2 little ovoids that are on the side there. And that just allows us to cover basically this area, and the uterus gets treated as well, kind of winds up being that shape. And this device gets connected to a machine that has a little radioactive seed. So this actually does have a radiation source. And it's on a cable, and it travels down a transfer tube, so a tube connected to this device, and then it goes in and it sits in here for a given amount of time, and then it goes and it sits in this one, and it might move out and deliver that radiation dose from the inside out. And that allows us to get a much higher radiation dose into that cervix area, which is important for curing the cancer there, without having to go through other organs from the outside in. So, but this device can only cover, where we can get to with it. We can't really treat the lymph node areas, which are also important. And so that's why it's a combination of the 2. All right, and then I think we're gonna move on to endometrial cancer. Yeah, so I don't know if we wanna do any questions about cervical cancer at this juncture.
Any questions? I don't see any questions in the chat box, Dr. Gomez.
Okay, so we will move on. All right, so we're gonna move on to endometrial cancer now. So in our diagram here, that's basically here. So uterine cancer, which most often comes from the inner lining of the uterus, or the endometrium here. This is the muscular layer, or the myometrium there. All right. And so uterine cancer is actually the most common gynecologic malignancy in the United States. It's 4th most common cancer in women. And it's about the 6th most common cause of deaths from cancer for women. And generally, uterine cancer will present with abnormal vaginal bleeding. So most often in a postmenopausal woman that has finished her periods many years ago and then starts having some spotting or bleeding again. Sometimes that's just a little bit and kind of here and there. Sometimes it's a lot. But basically, anytime you're having bleeding after you've stopped your periods, you should definitely go in and have that evaluated. It's not a guarantee by any means that you have a cancer brewing in there, but it could be. And so really important to get that checked out. As you can see here, there's about a 9% risk in women that have bleeding after menopause that it is an endometrial cancer. So it's not a super high risk, but definitely something you should get checked out. It's not normal to have bleeding after you finish menopause. And then in premenopausal women, they might have heavier bleeding or more prolonged bleeding between periods. And so that's good to get evaluated as well. And then less commonly, you might find some cells on a Pap smear that seem more consistent with an endometrial cancer versus a cervical cancer, but that's not the most common way that it's diagnosed. And the risk factors for uterine cancer tend to be revolving more around high levels of estrogen, basically. And so if a patient has obesity or diabetes, basically having more fat cells in the body, there's a protein that converts fat to estrogen. So if you have more fat cells, then you generally have higher levels of circulating estrogen. And so that can lead to these uterine cancers. And tamoxifen is another potential cause for uterine cancer, but it's a little bit different one. And then increasing age. There's kind of two different types of uterine cancers. One's more estrogen related and tends to happen in a little bit younger women. And then there's one that tends to happen in older, skinnier women that can sometimes be a little more aggressive. So, but it can be in either of those risk groups. And for uterine cancer, there is actually no screening guidelines, nothing that's really effective. But the good news is that, it's something noticeable when you have the postmenopausal bleeding, and a lot of times that's present. So many times these can be caught at an early stage. Not always, but a lot of times. And the main treatment for uterine cancer, pretty much everyone, unless they have other medical problems and can't have a surgery, there's always surgery involved for these. And that involves removing the uterus and the cervix, as well as the tubes and ovaries, and generally sampling some of the pelvic lymph nodes if that's possible. And that information that we gather from surgery allows us to make recommendations on whether anything additional is needed. So in some cases, we add radiation, and in some cases, we add chemotherapy. And if it's a little bit earlier stage, not really, as widespread, sometimes we're able to do something called vaginal brachytherapy alone. And I'll show you what that device kind of looks like. But that's generally about 5 treatments, just treating 3 or 5 treatments, treating just the top half of the vagina. But if it's a little bit more advanced, invading further into the wall of the uterus, or a higher grade, then sometimes we also treat the pelvis and those pelvic lymph nodes there. And so that we would do with external beam radiation. And if it's involving the cervix, then we usually use a combination of the two. And there are other reasons to do that, but that would be one of the more common ones for that. And chemotherapy usually comes into play with some higher risk types of uterine cancers, or if there are lymph nodes involved, or the area next to the cervix, then chemotherapy would also be utilized. And this is what the vaginal cylinder looks like, because with cervical cancer, you have the cervix there and the opening to the uterus. And so there's the tandem, that stick that kind of goes in to be able to treat that whole area, and the ovoids on the side. But once you've had your surgery for uterine cancer, basically everything up above gets removed, the uterus and the cervix, and then the top of the vagina gets sewn up. So you just sort of have a potential space in there. And so the cylinder works quite nicely we want it to be as large as possible to fill that space and be right up against the walls there. And then we just treat the upper half. And this also, like the tandem and ovoids, gets connected to the machine that has a little radioactive seed that goes in and sits in there. All right, I guess since there weren't, we'll just move along and do questions at the end if there are any. So the next one is ovarian cancer. And as you might guess, this is involving the ovary there. And ovarian cancer is not as prevalent, so a little bit more prevalent than cervical cancer, but still not very common overall. But in terms of incidence, but the risk of death with ovarian cancer, unfortunately, is quite high. And so that is above uterine here. Despite the fact that there's only about 22,000 estimated cases for 2020, we have almost 14,000 estimated deaths. So unfortunately for ovarian cancer, the symptoms that are associated with it are really quite vague. So it can be that the belly is getting a little bigger, you feel some bloating, maybe feeling fuller a little quicker. You could develop a blockage of your bowel or have a mass that's found on pelvic exam or incidentally on some imaging. But a lot of times once you're getting to the symptoms where you're having more bloating or enlarging abdomen or things like that, the ovarian cancer tends to be a bit further along in terms of its staging and having potentially spread inside the abdomen there. It can go other places in the body, but most often it's spreading kind of in the abdominal cavity. And risk factors for ovarian cancer include older age, not having pregnancies, early periods or late menopause, and also there's some genetic syndromes that are also associated with it, like the BRCA1 and 2, which is most popularly or most commonly known, I guess, for being associated with breast cancer, but also associated with ovarian and Lynch syndrome as well, which is another genetic syndrome. And there, unfortunately, is no good screening for ovarian cancer. Things that have been looked at include a blood test for CA-125, which is a marker that can be elevated in ovarian cancer, but hasn't been found to be beneficial in terms of a screening tool. Also, vaginal ultrasound, you can go in there and take a look, looking for any cysts or masses on the ovaries, but in terms of the benefit of doing that versus, finding the ovarian cancers early or having some sort of a benefit in terms of diagnosis hasn't been found. And for that reason, there isn't any recommended screening. And then treatment of ovarian cancer generally involves surgery to what we call debulk, or if you can catch it at a very early stage, then that's really the best, and then that ovary would be removed. But if it's at a later stage, then it might involve, just taking out any tumors they can find there, trying to get it down to as minimal as possible, and then following that with chemotherapy. Generally, radiation is not involved for treatment of ovarian cancer, although in some limited cases, we may use radiation for an area that's causing a lot of symptoms or something along those lines. It's what we would call palliative intent of radiation. So using it to help with pain or some other symptom that we think, if we shrink a tumor in a given location or try to control it there, that it might be helpful for symptoms. And then vulvar cancer is our next one. And so that's down here. And here's just another view of the female anatomy here. So vulvar cancer can involve the labia, or the lips down here, labia majora, that's kind of the bigger outer area there, or the inner lips here, the labia minora. Can also involve the clitoris or the urethral opening. Sometimes they extend down and even involve the anus down here, or this part up here called the mons pubis.
If you want to come in and they can just redraw your blood.
Question?
Wait a second. It wasn't good?
Yeah, she said it's called like a hemoglobin.
So vulvar cancer is really quite rare. As you can see, this is the lowest incidence that we've seen thus far, and deaths from vulvar cancer are also on the rare side. So basically vulvar cancer is thought to be caused by two main processes. About half of the cases of vulvar cancer are associated with HPV infection. And then the other half are really related to chronic inflammation. So there's a condition called vulvar lichen sclerosis, is kind of some thickening of the skin and chronic itching. And so having chronic or kind of long-term inflammation or itching or scratching of the skin down in the vulvar area can potentially cause a cancer at some point down the line, or it can be, related to HPV. So prior history of cervical cancer is a risk factor for vulvar cancer, mostly because cervical cancer is also related to HPV. Cigarette smoking can also be associated as well. And generally the symptoms of vulvar cancer include either noticing a spot on the vulva that's a thickened area, or an ulcer, or even a frank tumor looking area. Itching is a very common presentation for vulvar cancer. And then if you have a lesion there, sometimes there can be bleeding or pain associated with it. You can also notice like a lump in the groin area. And if it was more advanced, potentially causing urinary or bowel symptoms. And again, for vulvar cancer, there's no screening available. Really, the only gynecologic cancer that has routine screening available is cervical. And treatment of vulvar cancer, again, depends on how advanced it is. So if it's caught very early, it might be just surgery alone. In some cases, it's surgery followed by radiation to reduce the risk that it comes back after the surgery. Or sometimes we use chemotherapy in addition to radiation to help the radiation work better. And in some cases, by the time that we get to it, or that it's diagnosed and found, it can be quite large and surgery might not be possible. And so in those cases, we would consider treatment with radiation and chemotherapy alone, or sometimes doing that first to try to shrink things so that a surgery might be possible. One just other point for vulvar cancer. So basically, I think it happens, we tend to see a lot of the cases in older women. And I would say if you're noticing any irritation, itching that seems persistent in the vulvar area, it's just really important to get to your gynecologist to have an exam and have somebody just take a look. It could be something, very benign that could maybe just need a little steroid cream or something like that. But if it's ignored, then it's just these cancers we tend to see fairly often once we see a vulvar cancer. We don't see a lot of vulvar cancer, but we do see it sometimes. And they can be these large tumors that it's just unfortunate that no one, really took a look down there for quite a long time. And so really the best thing is just pay attention to your body. If you're noticing an issue, just please go and have it checked out. And then the last one we're going to talk about is vaginal cancer. So this one, the incidence is pretty similar to vulvar cancer. It's also very rare. I would say in terms of my experience, I see vaginal cancer even less often than vulvar cancer. The vagina can be involved with other cancers. So the cervical cancer could grow down into the vagina, or vulvar cancer could grow up into the vagina. So we're always, whenever we see a vaginal cancer, in terms of the process of diagnosing it, then you have to look for those other areas where it could be extending from. But vaginal cancer just by itself is really quite rare. But it does happen. And so here's the vagina there. The most common symptom of this is, again, vaginal bleeding. And as many as 20% of women may have no symptoms at all, but sometimes a mass can be felt in there. And again, if it's more advanced, you might have urinary symptoms or problems with bowel movements or pelvic pain, things along those lines. And most of the cases tend to be related to HPV, so similar risk factors to cervical cancer, including multiple lifetime sexual partners. Being a current smoker is also a risk factor. And treatment, depending on how advanced it is, sometimes if it's a limited area, surgery may be an option. A lot of times we're doing radiation with brachytherapy, so something to get the dose in there a little bit higher, and sometimes chemotherapy is involved as well here. And that's it.